I'm going to talk about ICH, and I don't have anything to declare concerning that talk. So ICH is still a devastating disease, and we know that it affects more and more people, also in Western country. And what's intriguing is that every fourth patient gets worse after we see the patient in the hospital. So it seems that there's still something we can intervene in the very, very early phase. From the location point of view, it's important to determine the location in the acute phase. It could be a lobar location or a basal ganglia location, thalamus location. This is also important because we know that especially these patients have a poor prognosis because hemorrhage and all the associated factors go to the midbrain and maybe also the brainstem, and especially the brainstem also has a very, very poor prognosis. In terms of the pathophysiology, and I come to that when talking about clinical trials, it's important that we differentiate between hypertensive bleeding and also amyloid bleeding because they are totally different entities. So what is new and what is the evidence? I think there is a clear evidence that patients do better when they get a proper neurocritical care management in specialized ICUs. And this is a very old study from Michael Diringer proving survival benefit, but there is also a decrease in length of hospital stay, a decrease in mortality also in long-term shown. And nicely, the Neurocritical Care Society published these standards of neurocritical care. So what should a neurocritical care unit be equipped with as a stage 1 or standard 1 neurocritical care unit? So if we come to treatment and novelties in treatment, I think every one of you knows these patients which get an hematoma enlargement in the very early phase. So this is something we have to think about, where are our treatment strategies. And the other point, what I would like to point out is that certain patients have a progression in the perihematomal edema enlargement. And still we don't know which patients at the beginning actually run into that category versus the other patient population, ICH patients, which don't have these large perihematomal edema. So what could be the targets? The targets could be blood pressure management, and I say it's the ICU care bundle. Then we have to talk about anticoagulant treatments because NOAC treatment is very prominent these days. And then there are some advances very recently, also not fully published papers on microsurgical approaches. But obviously, if we talk about new targets, it's even broader. We can talk about inflammation, we can talk about disruption of the arteries, about hemoglobin, about iron decomposites, and also there are some studies ongoing, like the capturing of iron, and in this study, it seems to be that there is a subgroup of patients with benefit most, and this is what we also see in other trials. The ones with a small hematoma are totally different to the ones with the intermediate hematoma between 30 and 80 cc, and the ones with a very large size hematoma. So meaning that certain interventions are specifically better in certain patient population, and the next trial on desferoxamine is going to be in that intermediate patient population with a hematoma size of 30 to 80 cc's. But as also said, there's lots going on in the brain in the perihematomal area with inflammation, and there are already some trials, also anti-inflammatory drugs in ICH patients. And we also know about the CHINCH study, about the hypothermia study, which was unfortunately not prolonged to the end, but we know that there is a certain effect also in the perihematomal edema. So what is the evidence blood pressure monitoring in the ICU bundle? I think you know these two studies. This is the INTERACT study and the ATTACH-2 trial. And both trials aimed to decrease the blood pressure very early in the first 60 minutes, partly with a specific treatment and here with an unspecific treatment. The outcome was that there was a trend for a better outcome in the INTERACT trial, and the ATTACH trial was actually a negative trial. Was stopped due to futility because there was more side effect of renal side effect, especially in the intervention group. I want to draw your attention. The median size of the ICU volume is 10 cc or 11 cc. That's important to understand also the effect and the recommendation in the guidelines. So where we saw the most side effects is in this group of the severe blood pressure decrease in the ATTACH-2 trial with the renal side effects. And a post-hoc analysis compiling all these studies together showed that a mean reduction within 60 minutes around 140, 150 millimeters of mercury seems reasonable and is associated with better outcome. And that's why we have the recommendation now for mild to moderate severity, which also means the intermediate size or small size hematoma. It's safe and reasonable to lower the blood pressure to a range of 140, 150, and that's actually what we recommend now in the guidelines. But there is a very open, or we don't have the answer for large and severe intracerebral hemorrhage patients. And so that's why we made an observational study in our cohort and looked at brain tissue oxygen tension and microdialysis by invasive measurements in the postoperative phase of severe ICH patients. And what we found is that in patients with a targeted blood pressure, which is recommended by the guidelines between 130, 140 to 150, we actually increase the brain tissue hypoxic load in the brain. And that's why in our institution, and this is obviously not a recommendation for general, but this is what we observed, that the higher blood pressure may be beneficial, especially in these patient population with larger size hematoma. And that comes to kind of an individualized care that's not recommended by guidelines, but this is just a sense what we do in clinical practice. So what about the INTERACT 3 trial? And this trial was published just a few months ago, and I think that's also a very intelligent trial, a follow-up trial of the INTERACT 2 trial. And they defined an ICU bundle. And ICU bundle means control blood pressure, control glucose, control temperature, and obviously reversal of warfarin-related anticoagulation. Why warfarin? Because only centers were selected which did not have a protocol at the beginning. And this is also maybe why you see these countries here who contributed. And they started in their regular care of patients without having a certain protocol for all these interventions. And then they started with the intervention, and the intervention was just introduce the protocol and have targets as outlined here for blood pressure, glucose, temperature, and so on. So what are the results? I think the first question is, when did they intervene most? And mostly they intervened, the most intervention were in blood pressure control, and this is important. And only in 8% of the patient they targeted a specific glucose, so they lowered glucose, antipyrexia treatment also in 10%, and correction for abnormal coagulation was very rare. And this is also why this is important to know. It was not in our areas where so many NOAC patients are around. It was in areas where only a few patients were on anticoagulant treatment. So the treatment effect was not that large. You see the reduction in systolic blood pressure and diastolic blood pressure in glucose, and temperature was even no significant change, so meaning that the patient didn't have fever, and so they didn't have to intervene. And this is also important when you interpret the results. The median size was 15 cc of ICH patient population. I think this is also something we have to take into account. And this was a positive study. And I think this is a very, very interesting information now, that if we apply a proper care bundle in neurocritical care, and which means normalization of temperature, normalization of glucose, and targeting a specific blood pressure, it makes sense and improves outcome. So this is an important information, specifically for institutions who don't have strict protocols on that. Another part I want to touch on is coagulation. There are very nice recommendations now how to deal with patients on anticoagulant treatment, and I think by the guidelines. And for vitamin K antagonists, I think straightforward, give PCC for correction rapidly. For dabigatran, also very nicely, idarucizumab, if it's available, treat that directly, specifically to antagonize the anticoagulant effect. For heparin treatment, protamine, and then you know about the factor 10A inhibitors, and andexanet alpha is is a matter of debate. It's already FDA approved and also by the EMA approved. And lots of institutions now say, well, should we apply that? It's rather expensive compared to PCC or not. And you see the recommendation, it's a class 2A recommendation for andexanet alpha versus class 2B recommendation for PCC. So what do the data show us? And I think that's important. The Annexa 4 study was a study including patients with severe bleeding, and that could also be gastrointestinal bleeding, intracerebral hemorrhage, or traumatic bleeding. And so the subset of ICH population is here. And it's important to know that the primary outcome was not mortality, and it was also not morbidity. It was efficacy in terms of the homeostasis, so that you correct homeostasis. Is this trial in terms of that effect positive? Yes, there is a good effect on homeostasis. So you correct the blood levels, you correct the effect of the anticoagulant treatment. And the big question is always, what are the side effects if you do that? And the side effects also in this preliminary analysis published a few years ago was that thrombotic events were up to 10% in this patient population. But this was enough to recommend it as a specific treatment for factor 10A inhibitors, and that's why we discuss this now, whether this is an option for this patient population. A few months ago, the final data of this Annexa 4 trial were published, and you see that here, again, a very good effect in homeostasis. It's important that only a few patients with edoxaban were included in the study, and mostly apixaban and rivaroxaban. That's why the strongest recommendation comes for these two medications. What about the side effects? There's a 10% risk of thrombotic events. This is also something we have to take into account. And so the question is, what about functional outcome? And there were two ways or two intentions to answer that question. The one intention was from a German group taking the Annexa 4 study population and compared to a PCC treated patient population in a registry, and this is the RETRACE registry. And again, what the authors found that hematoma enlargement was significantly decreased. ICH volume was also significantly lower in andexanet alpha treated patient. The reduction of the hemorrhage was by -7 milliliters. And there was no outcome benefit in terms of mortality or functional outcome. And this is also why we are awaiting the results of the Annexa I trial. And the results were actually just presented at the very recent World Stroke Conference, but I was not there, and I can give you a glimpse of that, and we have to wait for the final publication. But again, in this trial, the preliminary idea was to make an interim analysis at 450 patients and to compare andexanet alpha versus usual care, and the primary outcome was also efficacy endpoint, and a secondary or a safety endpoint, the occurrence of thrombotic events and all-cause mortality. You know that in June we have this information that the primary endpoint was met after the preliminary analysis, so after 450 patients. We know that again the hemostatic effect is there. And obviously we have to wait for the information on mortality and functional outcomes. So for now, we stay at these guidelines with the recommendation as a proposed, and you can, obviously you should follow the guidelines, and there are some open questions which I discussed. In the last 2 minutes, I would like to touch on novel ideas in the operative theater, because there is something ongoing you should be aware about. And I just posed a question about when is the optimal timing for neurosurgical operation? Does age matter? What about the GCS? How to identify patients? Is lobar hematoma different to deep hematoma? And what about novel advances in endoscopic surgery? Because I think that's also the way we're going to go in ICH patient population. So to open that discussion, we have to go back to the STITCH data, and the STITCH data were both studies, STITCH and STITCH 2 studies, which did not show an outcome benefit in the overall patient population with, and we have to admit that, a rather unstructured approach how the neurosurgeon addressed these ICH patients. So it could be that one neurosurgeon made a mini craniotomy and tried to get as much volume out of the brain, and in another site there was a hemicranectomy made, or a larger craniotomy, and then the bone flip either in or out. So it was not a very structured approach towards the patient population. But there was a signal that an intermediate patient population, and especially the patients with a very surface-located hematoma, may benefit from that intervention. So as years go by, also the neurosurgical procedures get better, and this is the MISTY trial, and the MISTY trial was a trial where hematoma of a size larger than 30 cc, very important, were tried to get by aspiration and also by suctioning and applying alteplase into the core of the intracerebral hemorrhage to decrease the hematoma load. And it was actually very effective, because you see the 44 cc at the beginning and then 12 cc afterwards. And the primary outcome was good functional outcome defined by a modified ranking scale 0 to 3 at 1 year. And the primary outcome was not positive, but there was a sub-analysis, also a predefined sub-analysis, whether there is an outcome benefit in mortality, and this came out true, and there was a significant benefit in mortality, and that's why also the American Heart Association gave a level 2A recommendation for this intervention. So all in all, a negative study. The primary endpoint was not met, but we have safety data that such an intervention can be done, and there is not that much increased risk of rebleeding. But it's also important to know that only close to 60% achieved the target of reducing the volume to below 15 cc, and that's important. And there's a clear association between the more blood you remove, the better the outcome the patient actually is. And what is very important is now the ENRICH study, and the ENRICH study has a study protocol where a protocolized approach towards the intracerebral hemorrhage is done in every patient in the same way. And the idea is going in that frontal area through the sulcus, and then also in the way the fascicle of the brains are, so of the brain tissue are in the white matter. And so the idea is make little damage to the brain on the way to the hemorrhage. And I think that's a very wise idea, and they had the standardized approach. The outcome was the utility-weighted modified ranking at 180 days, and they included not the worst patients and also not the best patients, so no GCS of 16 is included. And these results also came through the media already before we can read the paper. So this is what we know also from the ESOC, that this is a positive trial. And the positive trial means that there is an outcome benefit, and there is a benefit that actually that intervention improves functional outcome by this utility-weighted modified ranking scale. But we also have to go into detail and to recognize that there was a preliminary analysis after 175 patients, and this was predefined whether the study cohort will show a signal in the lobar hematoma or in the deep hematoma patient population. And so the decision was go on with inclusion only lobar hematoma patients. And this is an important information what we have. So meaning 125 patients, which were included in the last section, and they were only lobar hematoma patients. Okay, so this is a positive study, but we have to see the final paper to make any conclusions. So to sum it up, I think care of these patients in the neurocritical care unit is an important strategy. It totally matters where you have your ICH located and and then obviously size matters. For small size hematoma, I think the aggressive treatment in the very early phase, like blood pressure reduction, and there's also some ideas of applying tranexamic acid. These are negative trials, but we wait for the TITCH-3 trial, so there might be an effect in this specific patient population. For middle-sized hematoma, we recognize that maybe microsurgical approach is something which we will recommend in future. It's not clear about the hematoma location, but what is obvious, the care of the patient does not mean to look at single items. You have to properly care these patients, look at temperature, look at other features in the neurocritical care unit. Thank you very much for your attention.
So thank you very much for that really fantastic talk through of ICH management. Does anyone have any burning question before we move on in the interest of time? Any questions? Please do also put them in the chat if you're a bit shy to come up. I've got one quick question, I guess I've always struggled with that idea of cerebral perfusion versus not allowing the patient to have an increased risk of bleeding. So how do you manage that with your CPP that you're now using in your institution?
So I think what we know from multimodal neural monitoring, if we put catheters in the brain, if we monitor brain tissue oxygen tension, there is another target, and that's why if we have that information, we actually titrate towards improving brain tissue oxygen tension, and that could be higher in a subpopulation of patients, as I alluded to. But in general, we have to follow the guidelines, and the guidelines mean rapid reduction, but don't go much lower than 140 degrees. And if I say 140, you anyway reach 130 or maybe 120. But there is a high risk of renal failure. And there's an interesting sub-analysis that especially patients with admission creatinine, which is already elevated to a certain edge, they have the highest risk, and that could be an identifier to not too much lower the blood pressure in the very early phase. And then about reversal of anticoagulant treatment, be aggressive very, very early.
Thank you.
There's one question over there. I don't know whether we have time.
I think it's quite a short one. I'm from Agata Andrzejska, I'm from Poland. I have a question. When do you think it's safe to start pharmacological DVT prophylaxis? Or strict only to non-pharmacological, or it's like 72 hours earlier on, because this is also a huge problem in ICU?
Right. So quite early, within 24 to 72 hours. We also analyzed our patients in our cohort. We usually start early. We don't see much side effects. So prophylactic heparin therapy, also recommended by guidelines. Start early. Don't wait for 3, 4, 5 days.
So thank you very much.